Hey everyone, today I want to share this really fun ECG with you from a 10-year-old male neutered Doberman Pinscher. We can see that we have a 9-lead ECG. So the top 3 lines show those 9 different leads, and then we have lead 2 along the bottom. And the first thing that I notice when I look at this is that I seem to have 2 different rhythms. A more narrow, complex, smaller looking rhythm in the middle, and then a wider, more bizarre, complex rhythm on either ends. So when I think about my interpreting questions, I'm going to sort of apply those to the 2 separate sections separately. And that might help me arrive at some final conclusions. So when I look at the section in the middle, my heart rate using the instantaneous 300 rule is somewhere between 75 and 100. I do think that the rhythm is slightly irregular. The P waves are present for each and every QRS, and QRSs are present for each P. The Ps look relatively the same, and the QRSs similarly look relatively the same. The PR intervals appear to be pretty constant, so I think those events are associated, and the Ps are indeed positive in lead 2. So my conclusion really is that that section certainly meets all my criteria for a normal sinus rhythm. Now, next we'll move on to sort of these, the bookends, the wide and bizarre stuff on either edge. And similarly, I'm going to apply those same interpreting questions to these sections. So heart rate here is quite variable, so the rhythm is irregular. And when I apply my instantaneous rule on the far right for sort of the longer interval there, the heart rate there is about 100. Towards the left, in the middle of that box, the heart rate's about 150. And then when you see it become fastest, it's about 215. So that sort of helps me frame my potential rhythm diagnoses when I think about the differing heart rates. The next question is, are there P waves for every QRS complex? And that's a really important one that I want to dwell on. So we're going to remove some of this masking and sort of brighten things up so we can see better. So P waves, are they there? And are they there for every QRS complex? And I really think they are, even though sometimes they get tricky to see. So I've outlined where I think the P waves are present with the arrows. And a really important thing to notice here is that the PR intervals are pretty constant, such that those P waves are tracking with the QRS complexes. So I already mentioned that the rate is changing. So these QRS complexes are becoming closer together and farther apart at various parts, but the P waves track along with that. Likewise, on the right-hand side, if I look for P waves, it is a bit tricky and maybe even more tricky than on the left. Where the heart rate is slower, I think I can point them out. That's where my arrowheads are, even though they are sort of getting eaten up a little bit by the preceding T waves in some cases, but I do see them popping out there. And then when the heart rate is slower, yet again, they're quite clear. So when the heart rate is the fastest at the section in the middle there, they're very likely to be buried in the previous T wave or previous ST segment if this pattern is repeating itself. So all to say, I think they're there. And importantly, I think they're associated. So concluding that there is AV association during this wide and bizarre rhythm is super important because that frames our differentials. So if I just make my way through a few more of these questions, QRS for every P, yes, I think there is. The P waves do in large part tend to look the same, although I can't say that with certainty because in some places they get hard to see and they get buried a little bit. The PR interval, I do think is remaining fairly constant. And sure, the P waves look like they're positive in lead 2. So for at least some of this, where the heart rate is slower, I still think it's a sinus-driven rhythm. It's just that the QRS complexes have taken on a different morphology, and we need to think of why that is. But if I just stick to a couple more points before I get to that, when the heart rate picks up faster, my differentials for that, when I'm concluding there's AV association, would be either an atrial or a sinus tachycardia. And which of those is it is might necessitate me seeing a little bit more rhythm in this patient, but the sort of abruptness of how quickly the heart rate accelerates makes me maybe lean a bit more towards an atrial tachycardia when the heart rate gets to be that 215. Although maybe there's something that, you know, startled this patient while we were running the ECG, not sure. So now, you know, coming to this wide and bizarre morphology of the QRS. Well, when we think wide and bizarre, we often want to jump straight to PVCs or ventricular tachycardia. But here's an example where that conclusion of AV association is not consistent with a ventricular origin rhythm. So another reason why complexes might look different is not because of their point of origin, but rather because of their pathway of conduction. And a bundle branch block is a type of conduction abnormality that alters the path of conduction. And so I think that's a reasonable conclusion here. Now, bundle branch block is not always an all or nothing phenomenon. And so I've circled this one heartbeat in the sort of zone of transition between the wide and narrow stuff. And it looks maybe somewhere in between, slightly different than the really normal stuff. And so I wonder if there's maybe some partial bundle branch block going on in that particular heartbeat as things change. And what is changing in this patient? Well, I think it's mostly heart rate. And so I'm beginning to think that this bundle branch block is really dependent on heart rate. When the heart rate speeds up, bundle branch block is present. When the heart rate slows down, that allows enough time for everything to repolarize such that the bundle branch block resolves. So how do I tie some of this all together? Well, I think we have an underlying sinus arrhythmia with intermittent bouts of atrial tachycardia, and in both settings, some left bundle branch block. Next time, we'll talk more about left versus right and how we tell. But I also want to point out that I pointed out the heart rate dependent nature of this. So I want to include that in my rhythm diagnosis. So I'm going to say with rate dependent left bundle branch block. I know that's a lot of content, a lot of stuff coming at you in one go. But some of the really important things we took away: finding P waves, so important. Determining whether they're associated. So concluding AV association versus dissociation, really important for our differentials. And we learned an additional differential here today for wide and bizarre QRS complexes. It's not always PVCs or VTach. We have to think about bundle branch block. And that's where finding P waves and determining if they're associated becomes really important. So hope you learned some stuff, and we'll see you next time.